a primary care pediatrician. Ah, okay. Hello, good evening, everyone, and welcome to the second webinar in the European Academy of Pediatrics Obesity webinar series. We are very pleased to welcome colleagues from across Europe and beyond, including primary care pediatricians, general practitioners, nurses, dietitians, and all healthcare professionals working with children and adolescents. Well, we are speaking about this because childhood obesity remains one of the most important and complex health challenges in pediatrics. Primary care has a central role in early identification, prevention, management, and long-term follow-up. It is often in the primary care setting that the first conversation with families take place and where meaningful ongoing support can begin. From a primary care perspective, one of the most important messages in that obesity should not be viewed an isolated problem or as the responsibility of the individual families alone. It is a complex chronic condition influenced by biological, social, environmental, and behavior determinants. And primary care professionals are uniquely placed to address this challenge because we are accompanying children and families over time. And continuity of care allow us not only to identify obesity early, but also to support sustainable change throughout childhood and adolescence. But let me say that today's webinar is particularly valuable because it focuses on a very relevant presenters on practical approaches that can help us translate evidence into everyday clinical practice. And I would like to thank you, the European Academy of Pediatrics, ECOG, ECPCP, and EPROBES, our speakers, and all participants for their commitment to improving children's health across Europe. I wish you an excellent webinar and please enjoy this one. But just before, we would like to present you a question by Slido to test your attention and your sensibility to this problem. Please connect to the QR code, and the active poll is about this question. What is currently the biggest challenge in managing childhood obesity in primary care? Please give your answer. Wow. It seems a very direct answer. Second one, very interesting. Oh, that's it. It seems to be that access to specialist referral pathways is not a problem. Well, now is the time to leave the floor to Dr. Marie-Laure Frelut, that is a pediatrician specializing in nutrition and childhood obesity. She has spent most of her career in Paris Children's University hospitals, and she is a founding member of SCOPE, past president of the European Childhood Obesity Group, editor of ECOG's first free obesity ebook on pediatric obesity, and was awarded with the French Academy of Medicine's Nutrition Award. She's deputy chair of World Obesity's Clinical Care Committee, so she's a very relevant speaker, and she will present his particular point of view about the issues that we have just presented with you with the Slido. Thank you, Dr. Frelut. The floor is yours.
Okay, thank you very much, Laura, and thank you very much to all participants to attend our meeting. So I would like to see my slides. Thank you very much. So what I propose you is to have another look at what we mean by childhood obesity, and mainly how we define it, what is now the epidemiology, and which are the trends we are facing. So please show me the next slide. So obesity has a apparently simple definition, which is the same as in adults, which is an excess fat mass. But in fact, it's not that simple because there are different locations of fat mass: subcutaneous, visceral, epicardial, etc. And there are three distinct tissues: white, brown, and beige. And those tissues, of course, are not in the same proportion. The dominant one is a white adipose tissue. Second point, also very important, is fat mass is below the skin, so we cannot access directly fat mass, and we have to use proxies to try to imagine which amount of fat mass a person and a child really has. Obesity is also a consequence of a gene-environment interaction, and that's very important from the point of view of prevention, of course. In order to constitute obesity, you have to have a lower energy expenditure than energy intakes, but it's not very evident to identify, especially in small children. And also, of course, obesity, even starting in childhood, is linked to later increased mortality rate and to short-term and lifelong severe complications. And even in children, respiratory complication, orthopedic complication can occur quite early. And of course, even in children, obesity starts being an individual psychosocial burden. So let's see, next slide. So this fat mass, as told you, is not directly accessible. And we have in children to take into account the fact that it varies with growth. What you see on this slide, on the right part of the picture, is that using as the best proxy the body mass index, which is weight divided by head square, we can follow the evolution of fat mass across childhood. In the first 2 years of life, it's normal for a child to be quite fat. Then he should slim down with a minimum of thinness at around 5 to 6, and then gain weight and a little bit fat mass. And in children, it's very important to use body mass index as curve, not as a figure, because this change in BMI reflects quite well the evolution of the subscapular skin fold, in other words, of the subcutaneous fat mass. That's why it's a very relevant indicator of excess fat mass or fat mass in general in children. Let's see, next slide. So, having said that, we have to try to decide which kind of growth charts we are going to use in order to assess the level of obesity. If we face a situation where the purpose is to describe an epidemiological situation, the choice is quite large. We can use International Obesity Task Force charts, World Health Organization ones, or national charts. If you want to use charts for clinics, you should not use the International Obesity Task Force reference, which is made out of a 6 population. We do not define a proper individual and a proper evolution. Let's see the next slide. So other measure can be used: skin fold thickness, trunk circumference, but they do not bring the same amount of information. And of course, even in children, you can use body composition measurements, in fact, impedance, MRI, DEXA. But there are, of course, second-line ways of assessing obesity. Next. On this slide, you see how a child can shift from early infancy, quite normal weight situation, BMI situation, to obesity. If you look at the blue and yellow lines, you will see that two children that were quite fat within the first 2 years of life followed very different way. The year one shifted to severe obesity, early severe obesity, while the blue one went back to a normal way of growing. If you then consider the green and pink lines, you will see that these children, which were quite thin within early infancy, followed very different way. The green one shifted to overweight, while the red or pink one remained quite thin. So this just shows, that just by looking at the way children evaluate from early childhood, you can grasp very much from their individual background and suspect genetic background, especially looking at the yellow one. Next slide. So let's go now to the way of to the epidemiological aspect around the world. Here you see on these slides from the WHO different evolution around the world. What is striking is that if you look on the left of the picture, in the 90s, there were already very big differences in the amount, in the prevalence of obesity. You see that some countries were close to zero, while others were around already 30% of obesity. And time going, most countries knew a very steep increase, but in one case, which is the European one, the blue line right in the middle, after some sort of plateau around up to the year 2000, a shift occurred, and then a new plateau, which hopefully could be due to public health intervention in order to prevent the development of childhood obesity in our countries. Then all other countries, all other parts of continents, you see, no quite parallel evolution to very high degree of prevalence. Next slide. On this slide, you can see how many children around the world are going to be obese in year 2040. You see that the increase is overall continuous. It's a linear increase with an expected number of 500 million children obese in the 40s, which means at least 25% of all children around the world being obese at that time, which is a terrible situation. Next. And WHO could show that this situation is tightly linked to the national income category in a population. What you see on this slide is that in high-income countries, the hyper level was reached earlier than in upper middle income countries, but that nowadays upper middle countries are above these high-income countries, and low-income countries are increasing as well, and in a continuous way. And the problem is try to stop this evolution before a catastrophic situation. So now we shall review the general factors contributing to the development of childhood obesity. Let's check physical activity first. So these data are issued from the European IDEFIX iFamily European cohort. And what you see on that is the link between the degree of obesity and the duration of moderate to vigorous physical activity. On the left part of the slide, in children 2 to 5 years old, the difference among the different categories of levels of physical activity is not that striking. When you shift on the right part in children 6 to 9 years, there is a significant difference in the amount of obesity between children that can move efficiently more than 60 minutes per day and the other two categories. So moving at an intensive level over 1 hour per day is extremely important for preventing childhood obesity and for helping children remaining in the right category of weight. Let's say another key factor, which is often considered as a secondary one, while it is absolutely important, is sleep duration. Here, still from the Idefix family cohort, you see striking results, which I shall comment, which have been confirmed in other parts of the world. If you look at children here, which are categorized according to duration of sleep, being correct at 11 or less hours, between 9 to 10 hours per night and less than 10 hours per night, whichever age range you consider, preschool or school children, the least children sleep, the more they tend to become obese. And you see that in preschool children, the odd ratio is almost 1.4, while in school children, it reaches to the enormous amount of 3.5 increase in risk of becoming obese. So why is that? Because it sounds quite strange that children that sleep less gain fat. In fact, sleeping less does not mean that they move more, that they perform more physical activity. It just means that they have a poor quality of life, and that in this poor quality of life, there is a lot of sedentary behavior, including use of screen and including, of course, then altered eating pattern. So a short sleep duration in children is a risk factor and is a way to detect that something is wrong in their lifestyle and in their later health risk. Next. So what about lifestyle regarding the amount and the variety of food eaten? You know that nowadays the NOVA food classification is often used in order to try to understand which pattern people and especially children follow. And the classical groups, which you know, unprocessed food, processed but culinary ingredients, or traditionally, if I may say, processed food, are now completed by the group of ultra-processed food, which are this kind of food in which there is not much left for healthy components, no more vitamins, no fibers, a lot of additives. So these food are not healthy at all. But let's see, next slide. These food are those which are very much liked by children because of their taste, because of the easiness of access, and because, of course, there is a lot of adverts about them. The adverts go through all sorts of media, including those that children use a lot. Beyond TV, there is now all sorts of screen, telephones and iPhones and computers and so on. And the budget for these adverts is absolutely amazing. It's over 250 billion a year used by the food industry to advert, with the main core being children. On the right part of the left part of the slide, sorry, you see how these you see how the proportion of this food has increased in several countries, among which there is especially the situation of Spain, which is readable because the line is in yellow. And you see that now in Spanish children, it has been found that over 20% of energy is coming from unprocessed food. But in UK, in school children, this proportion has now reached 60% of energy intakes. And this 60% is an indication that they will be hardly withdrawn from eating pattern, because it is now very much included in their general way of behaving. So the ultra-processed food marketing is a terrible situation because it has an impact, a direct impact on obesity risk and grade. Ultra-processed food is usually eaten by the same children that spend more time using screens. We know now that this kind of food are presented through adverts that children prefer to all other adverts for other types of food. We also know that there is an inverse relationship between healthy food consumption, especially fruits and vegetables, time and media, and consumption of these ultra-processed food. So that's a part of this food that is directly linked to obesity risk and grade. But beyond that, the consumption of this type of food is terrible because it seems that it is shaping attitudes and enduring beliefs about what is a normal way of eating. Children who eat this kind of food find it normal and will continue during their adolescence and adulthood. Next slide. So my conclusion, and it leaves time for discussion, is that right now the world is not very favorable to prevention of childhood obesity. We see that it is a growing multifactorial phenomenon. We better understand biological mechanism, but environment by itself that plays a key role is not favorable because of less place to play, because of the impact of advertising, and because, of course, of stress around children living in big cities, which are not especially designed for their pleasure. Our problem about childhood obesity is also that it decreases life expectancy and quality of life. And of course, young people are not always conscious about that. So at the end, a presentation like this one is a plea for an early prevention, including the various stakeholders from local to European level, and which I'm by stakeholders, I include, of course, people involved into the field of health, but also people involved in the field of economics and politics. Thank you. So just a last slide, of course. This is just to tell you that most reference I've quoted may be found in the ebook on child and adolescent obesity, which is on our website. And I invite you to use it at your convenience and to make suggestions about its content. It is available in 5 languages.
Dr. Frelut, my very best compliments for your excellent presentation. And now there is the time for some questions. Please put your question on the question and answer mode on the screen. and we will try to give you the answer. Obviously, thank you to Dr. Frelut. In the meantime, that we are waiting for the question, oh, I see there is this question now. Are there any common misunderstanding around definitions or classification that you think clinicians should be aware of in obesity? Dr. Frelut.
Well, the point, if is different whether you face a single child, single patient, and whether you have to give indication about an epidemiological situation. When you face a single child, if you have national references, it's better to use them because it reflects a situation in your own country. If you don't, you may use the WHO reference curves because they were built for children up to 5 years of age on a longitudinal way of breastfed children, and then after on sequential observation of children all around the world. So that's my suggestion is to basically refer to national or WHO curves.
Very, very good. Thank you. There is only one more question. This is the question. Based on current European trends, what should primary care professionals be most alert to when assessing obesity risk in children?
Well, I think that you should not focus on a single point, but try to evaluate which type and level of risk factors an individual child is facing. In some children, it may be just one point. For instance, in big cities, children not being allowed to move. And in other children, there is a whole range of abnormal situation, including, of course, altered pattern, eating pattern, too short sleep, or too low physical activity level. So try to have a sort of broad understanding of the individual situation.
Well, very nice, Dr. Frelut, because your presentation and your answer are really accurate, wide, comprehensive. Thank you so much for your
Thank you for
contribution. And now I can present you the next presenter of our webinar, that is Dr. Julio Álvarez-Pitti. Dr. Pitti is a pediatrician and a researcher based in Valencia, Spain, in the General Hospital Consorcio Universitario de Valencia, sorry. And he's a researcher within the IPedTech group and collaborator with CyberObinen. His clinical and scientific work focuses on multidisciplinary obesity management and cardiovascular prevention in children and adolescents, and digital health innovation. So he is another very important expert in childhood obesity and particularly cardiovascular issues and obesity, and he has participated in multiple research. So we are listening to Dr. Pitti. Please, the floor is yours.
Thank you so much, Professor Reali. I think I'm not sharing what I want to share. Let me
It happens.
here. Okay. And here. Okay. Huh? Okay. Now I got it. Thank you so much, Professor Reali, for your introduction, and good morning to everyone. It's a pleasure to me to be here in the European Academy of Pediatric webinar series. And today we are going to talk about a very practical topic of our daily work, which are practical tools for identifying obesity in the primary care setting. Our goal is to review how can we move from just measuring weight to performing a true holistic assessment of our patients. So over the last 20 years, we have witnessed a revolution in the concept of obesity in children and adolescents. We have moved away from considering it a condition that promotes the development of diseases to define it as a chronic disease based on adiposity, as defined in the position statement of the ESO, which clearly defines obesity in children and adolescents as a chronic disease. These scientific positions have led to an increasing number of national health systems considering obesity as a disease, including the European Union in 2021. We have gone from attributing the main cause of obesity to an energy imbalance between what is eaten and what is expended through physical activity, with a certain genetic predisposition, to understand that obesity is a multifactorial disease where increasing importance is being given to the genetic predisposition and other factors such as environmental, economic, and psychological factors. And in addition, each of these factors can be related to one to another, which makes obesity a very complex disease. That old outdated interpretation of obesity stigmatizes people who suffer from it because it is considered to be a disease that one brings upon oneself and which one is responsible for choosing to have unhealthy habits and for lacking willpower. But now, science has shown that obesity is a chronic and recurrent disease whose control is beyond the will of those who suffer from it, and that once established is very difficult to treat, even with the new GLP-1 drugs, as it has been shown that in many cases, when they are withdrawal, the disease reappears. None of these will be a public health problem if obesity were not so prevalent. Obesity has become the most prevalent chronic disease in childhood and adolescence, affecting up to 16% of children in Spain. And while obesity has decreased slightly in the last decade, obesity in Spain is now a matter of social class. Rates are falling for the privileged but rising for the poor, with a 12-point gap between the richest and the poorest. Obesity has become a disease of the vulnerable. And what are the keys of this paradigm shift? First, we finally understand the complex biology of adiposity. Second, we recognize the role of the brain and the environment in appetite. And third, we now have a game changer, highly effective GLP-1 medications. Over the past 2 years, we have had new editions of the American and the Canadian guidelines of management of obesity. During the next 15 minutes, I will try to extract the essence of them in terms of diagnosis and evaluation, applying in the primary care settings. And both guidelines emphasizes one thing: obesity is much more than the BMI CETA score. So what do we have to do to understand this? The Canadian guidelines emphasizes into a holistic assessment. We need an approach based on the 4M's framework of the Edmonton Pediatric Obesity Staging System. The first M to evaluate comorbidities, the second M to evaluate the mechanical physical limitations, the third, the mental health impact of the obesity, and the last point, the last M, is the milieu, which means the social environment and family barriers. This framework forces us to evaluate and treat the whole child and not just a number on the scale. And how do we manage this in a busy primary care clinic? We use, as the Canadian guidelines recommend, the 5 ACE workflow. The first asks for permission to discuss weight using an anti-stigma, person-centered approach. Assess the health risk using the 4Ms and morphofunctional tools. Advise on treatment options and risk. Agree on realistic collaborated goals with the family. And assist the family, providing resources, follow-up, or special referrals in some cases. So we have to make a morphosocial functional evaluation, and we have some tools. For the morphological evaluations, Professor Frelut has shown us that BMI still is a useful tool, and BMI CT score, and the guidelines, both American and Canadian, also show us that we have to continue using the BMI to make the diagnosis of obesity, with the difference that in the Canadian guidelines, they recommend the WHO curves, as Professor Frelut has told us, but the American guidelines recommend those of the CDC. And what about the waist-to-height ratio? Well, but this is an excellent and simple tool. Research shows that a weight-height ratio greater than 0.5 is a strong indicator of central adiposity and cardiometabolic risk. It tracks visceral fat better than BMI in many cases, requires no complex charts, and has a single and easy-to-remember cutoff. But current evidence does not show that waist-to-height ratio consistently outperforms BMI for pediatric obesity or cardiometabolic risk screening. A practical approach could be continue using BMI and consider adding the waist-to-height ratio, especially in older children and adolescents, to better capture central adiposity and communicate risk. So how to make the social evaluation? Of course, we make of history, of clinical history, but also we can use short electronic self-administered questionnaires that families can fill out even in the waiting room. For nutrition, in Spain, we use the KidMen questionnaire, but in any other parts of Europe, questionnaires adapted to the diet style of each country can be used. In this questionnaire, when you score below 3, you have a low adherence or Mediterranean diet. It just takes a few minutes and guides our nutritional advice perfectly. What about to evaluate physical activity? We can use several questionnaires, like physical activity questionnaire for children or adolescents, but a shorter questionnaire is a PALC. It classifies patients as sedentary, moderate, or very active in less than 10 minutes. It is easy, accessible, and validates the real-world movement habits. In all these questionnaires, you have this QR code in which you can download the literature. But if you don't have time to make this questionnaire, at least use the exercise in medicine physical activity vital signs. We ask just 2 simple questions. First, how many days a week do you engage in moderate to vigorous physical activity, and for how many minutes? And with these 2 questions, multiplying these minutes give us the total minutes per week, allowing us to check if they meet the recommended guidelines immediately. Screen time, as you all know, is a massive component of the obesogenic environment. Using screen time questionnaires validated by the European HELENA studies allow us to precisely quantify sedentary behavior in adolescents, helping us negotiate realistic screen time limits with families. And what about sleep? Sleep duration, as it has been said by Professor Frelut, are directly linked to metabolic health. The pediatric sleep questionnaire is a brilliant tool. The short version focuses on sleep disorder, breathing, snoring, and daytime sleepiness. If the score is higher than 0.33, it's positive and alerts us to a high risk of sleep apnea. And to check the mental and emotional impact, the pediatrics quality of life inventory is widely used and is also self-reported by the patient. It helps us quickly identify physical limitations, psychological impact, and a level of stigmatization the child is experiencing in their social life. To end, in some cases, is also needed to make an evaluation of the eating behavior. The Yale Food Addiction Scale for Children is easy to administer and help us to detect early signs of food addiction, binge eating, or loss of control around food, which requires specific psychological support. Moving into functional evaluation, cardiorespiratory fitness is an independent marker of cardiovascular health. We can evaluate it in a simple 3-minute step test using standard staircases. By measuring the pulse before and after stepping up and down for 3 minutes, we can assess their fitness level using the hypertelnet protocols. Here you have the QR to download it. For this, it is also only necessary to use a chronometer and a step and to calculate the changes in heart rate that occurs before and after exercise. This is a work made in collaboration with Professor Wojcik from Krakow, and you can have this tool in this link. But also, muscular fitness is vital. Using a simple hand grip dynamometer in the clinic take less than a minute and give us an objective measurement of muscle strength. Low muscle strength combined with high mass is a high-risk phenotype that requires target exercise prescriptions. And what about the other comorbidities? The American guidelines are highly prescriptive regarding lab work. For any child over 10 years old with a BMI in the overweight range, we must check fasting lipids. If they are in the obesity range, we must perform a deeper screening, including fasting lipids, glucose metabolism markers like fasting glucose or a glucose test if possible, and hemoglobin glycosylate, and also liver enzymes to check for fatty liver disease. So let's have a look deeper at the EOS metabolic staging criteria. In terms of evaluation, the metabolic impact, stage 0 means completely normal values. Stage 1 involves mild abnormalities like prehypertension and mild transaminase elevation. Stage 2 means established complications requiring medication, such as clinical hypertension, type 2 diabetes, or severe fatty liver on ultrasound. And stage 3 means uncontrolled or advanced end organ damage. What about the evaluation into the mechanical area? Stage 1 means mild joint pain or mild apnea. Stage 2 involves moderate limitations in activities of daily living or sleep apnea requiring CPAP. And stage 3, severe limitations. What about mental? Stage 1 is mild anxiety or mild body image concerns. Stage 2, major depression, frequent binge eating, or severe body image disturbances. And stage 3 represents uncontrolled psychopathology or complete school refusal. And to finish, the social milieu, stage 1 involves occasional bullying or minor family communication issues. Stage 2, significant bullying, poor school attendance, or moderate financial limitations. And stage 3 involves severe family crisis, domestic violence, severe financial distress, or unsafe home environment. Why do we stage? Because it guides our management plan. Stage 0 and 1 should be managed right here in primary care, focusing on monitoring and healthy lifestyle counseling, perhaps supported by a local dietitian or mental health professional. But in stages 2 and 3 requires a referral to a multidisciplinary special pediatric obesity unit because they need intensive medical, psychological, and potentially pharmacological or surgical interventions. So just let's practice it with this case, with clinical workflow. Two real cases that look similar on paper, but are completely different when we apply the tools. We have Maria, 10 years old, with a BMI of 28.8, and John, 40 years old, with a BMI of 35.7. Making the evaluation of the BMI and using the WHO growth chart, we can see that Maria suffers from obesity, but John suffers from severe obesity because it's over 3 standard deviations. We look into their medical history. Maria has a family history of obesity, but her environment is stable and supportive. John, however, has a history of snoring, suffers from bullying at school, and his father works in a restaurant with late hours. John is already showing signs of mental and social complications, making him at least having an EOS pediatric stage of 1 or 2. Our digital questionnaire reveals even more. Maria has a KidMed score of 5. She eats fruits, plays basketball. Her sleep questionnaire is negative, so stages 0 in the EOS. However, John follows a processed diet with sugary drinks, reports high anxiety, spends 8 hours a day on a screen, has leg pain that limits his movement, and his sleep questionnaire is positive. John is clear is in a stage 2, based in mechanical and mental health indicators. Looking closer to sleep, Maria has a regular sleep time and PSQ is negative, but John has computer in his room, coughs frequently at night, and his pediatric sleep questionnaire score is 8 out of 21. This is positive, high probability of a sleep apnea. The physical examination confirms this divergence. Maria has mild lipomastia, but no other major signs, and John presents with clear acanthosis nigricans of his neck, of signs of insulin resistance, lipogynecomastia, henuvalgo, flat feet. John has a severe clinical signs of metabolic and mechanical disease. We measure blood pressure using appropriate cuff size and validate sphygmomanometer that we can see here in this QR code, and we can use the European guidelines using these tables to make the diagnosis of blood pressure, but also we can use the calculator of hypercholesterolemia that easily gives us the diagnosis of blood pressure. So we can see that John has the diagnosis of hypertension when we use the office blood pressure measurements, but Maria is normotensive. Following the guidelines, our lab work reflects these physical findings. Maria's metabolic panel is completely normal, but John's lab results show that glucose hemoglobin is higher, has an elevated fasting glucose, and elevated liver enzymes, indicating significant metabolic dysfunction. Our fitness testing shows a matched pattern. Maria's scores are normal, but for John's, both cardiorespiratory fitness and muscular fitness is far low of normality. In the Yale scale, also with Jones, we have a positive Yale scale, and this we have to look more deeply into this. So let's look at our final staging. Maria has obesity, but she has not metabolic, mechanical, mental, or social complication. She is in stage O of EOS stage, and we can manage safely in primary care with regular follow-up and lifestyle counseling. On the other side, John has severe obesity with multiple moderate complications, hypertension, insulin resistance, suspected sleep apnea, gait issues, and a binge eating disorder. He is in an EOS pediatric stage 2 or 3. So, in this case, we have to refer, and when it is referred, it is confirmed that he is suffering type 2 diabetes. Also, he suffered of hepatic steatosis, and also when we make the polygraphy, he is confirmed the severe obstructive sleep apnea. This detailed slide displays all these dysfunctions. So John cannot be treated with simple lifestyle advice in primary care. He requires immediately refer to our specialized multidisciplinary tertiary unit. To conclude, our role in primary care is to look beyond the scale by using clinical history, physical explorations, also we can help with simple digital questionnaires, weight to health ratio or BMA, and the ESP statistics framework. We can identify which patients can be treated effectively in primary care and what children need to receive specialized help. Thank you very much for your attention.
Dear Dr. Pitti, thank you very much for your excellent presentation. So we could summarize that after definition, epidemiology, and trends presented by Professor Frelut, and after practical tools for identifying obesity in the primary care setting presented by Dr. Pitti, we have a very wide panorama of the obesity situation in Europe with a lot of particular. So I would like to launch another question and answer section. So please, I ask you to write it down, your question, in the proper site, in the question and answer site, and I will transmit them to the presenter. I have two questions. The first one is about what about drinking of water in the prevention of the obesity? And the second one is I am interested to the informations about the correlation with obesity and reproductive health in future. But I suppose that this kind of question could be proper for the next presenter that she is an endocrinologist.
Mm-hmm.
So it's up to you.
No, well, about the question of the prevention,
Yeah.
I think that is the clue. As we have seen, obesity once established is very difficult to treat, and pediatricians, we have the chance to prevent it because we knew our children since they are born, and even earlier, we knew their parents. So I think that we have a unique opportunity to make the intervention to those young parents who are expecting to have a children and trying to change their habits before the children comes to their house. And I think that we have there a chance to avoid and to decrease the epidemic of obesity, because once it's established, we all know that it's difficult. And nevertheless, we have to treat our children with obesity and to use all these tools from primary care. And there are only a few children that needs management in hospitals.
Very nice. The last question, it's a wider one. In a busy primary care consultation, which tools or indicators would you prioritize for early identification, and which kind of screening is more consistent without making the consultation for the child or the family, the specialistic consultation, I mean?
Okay, thank you very much for the question. I think that
It's
we
a
have
hard
reviewed.
question.
Yes, I
Yeah.
think that we have reviewed in the presentation.
Yes.
We measure what we have to do. But just to add another point, there are several studies that have been able to predict the possibility to develop obesity in the first 5 years of age. And the point is the increment in the slope of BMI.
Mm-hmm.
So Also, it will be very important during these first years of age, not only to start with intervention when by BMI or waist to height ratio we have the diagnosis of obesity, but also before, if we see that it's a a fast increment in the slope, there we also have a chance to avoid the development of obesity.
And so that is the first and most important issue that you can check and that you can prioritize. This is a very good answer, in my opinion. Thank you.
Thank you so much.
You're welcome. So I would like to pass to our third presenter, Dr. Irén Kantor, that is a Hungarian pediatric primary care physician with professional interest in preventive pediatrics, childhood obesity prevention, and child health promotion, and she's also an endocrinologist. She's associated with pediatric healthcare networks in Hungary and contributes to initiatives focused on improving preventive healthcare services for children and adolescents. Her clinical work emphasizes early prevention, family-centered pediatric care, and health education. She's engaged in professional collaboration and educational activities supporting pediatric primary care and public health awareness, and she is participating in healthcare programs and professional meetings related to pediatric prevention and child well-being. So with so many activities, she will be best presenter to speak to us about what primary care role has, pediatric primary care role has to manage obesity and to connect in the long term of the follow-up of this kind of patients. Please, Dr. Kantor, the floor is yours.
Thank you very much for the nice presentation. I will share my screen. Okay, thank you. So good afternoon, everyone. Thank you, Laura, for the nice presentation, because my work is as a primary care physician to work with children on the individual level, and as a part and the head of the Primary Care Association, Pediatric Primary Care Association of Hungary, we are doing it in a community level too. So now I am trying to present what we are trying to do in Hungary, individual and the community level. So we developed an evidence-based management of childhood obesity in primary care. And the main message of my presentation is very simple. Primary care cannot solve childhood obesity alone. And the other message is that no effective obesity pathway can work without primary care. The primary care is the central to early identify the obese children. We need to develop a sensitive communication. We have to, as you voted, that family engagement and behavior change is very important. We have to develop and emphasize that the family has to engage with the program. We have to make the initial intervention. And of course, the follow-up and the referral in case it's need. So let's, I don't think that I will say something new, that why we have to talk about this in 2026, that because this topic is very urgent. Obesity has become one of the most important chronic health challenges of our time. More than 1 billion people worldwide are now living with obesity. And among them, hundreds of millions of children and adolescents are already affected with obesity, or they are at increased risk. The consequences are not limited to body weight, because childhood obesity is associated with hypertension, insulin resistance, as it was mentioned before, fatty liver disease, maybe severe sleep problem, musculoskeletal difficulties, reduced fitness, of course, stigma, anxiety, low self-esteem, and poor quality of life. And it also will track to adulthood. So this means that childhood obesity is not a lifestyle issue. It's clinically relevant and a long-term health condition. So let's see what Europe made for this. At the European level, this response became more comprehensive. Last year, the European Committee and the European cardiologist, they developed the Safe Hearts Plan. You can, scanning the QR code, you can go into particular details. And it is not a guideline, but it's a strategic framework to reduce the cardiovascular disease and all these related risk factors. This is highly relevant for pediatrics because the cardiovascular risk is not suddenly from Monday to Tuesday, and it's not beginning in adulthood. It develops gradually and often from very early in childhood because the children become obese, inactive, poor diet, and metabolic dysfunction they become. So what is nice to see in this Safe Hearts Plan that they want to focus on children and young people. And all European programs are divided in pillars. This project has 3 pillars. One is the prevention. This is support, trying to support and develop programs for healthy behavior, and all along the life course, not only from childhood, but also from adulthood. Secondary, as one question was focusing on this, that early identification. You will hear many times this slogan, know your numbers. This is the second pillar. So everybody will have tools that where are her limits in body weight, in length, BMI, cholesterol, and glucose, and all these numbers which can describe your risk if it has to be recognized that complication is developing or not. And the third is that, as we were talking about, that individual and the community level has to be connected, and the patients must have help from primary care. They must have specialist care. The community has to take care. All the services to help to develop a healthy generation, and all these things has to be coordinated. And all these pillars we are trying to apply in childhood. So this is what we started. We got quite a big sum from a company, and we developed a 5-year plan how to answer for this serious question. And our slogan is that it's easier not to gain weight than to lose weight. So I think this is the most important. And at the same time, we have to acknowledge that the prevention is not enough. Many children already live with overweight, so we have to prevent and treat obesity. At first, this task felt like mission impossible, but we changed it to possible, and also we emphasize it for the children. We didn't have enough time and enough resources, and the referral options were variable, and also our professional confidence was not so well-based. But we decided not to wait for the perfect system, and we started. So we were training our colleagues. All they were voluntary, and they got a special, and each half year they got a special education. And we emphasized on this course that the first and most important goal is the improvement of the mental well-being, the self-esteem, health, and quality of life. It's not only a simple weight loss about this program. The second was that we got professional help and education to learn about physical activity. And we made very simple aims. We go step by step. So we didn't, in the primary care, we don't have special measurements. So, but how we measure the improvement that reduce the breathlessness, improve the stamina, greater independence in movement, and children to participate in playing. And third is the dietary counseling. We as the only established diet for children is the Mediterranean diet. So we learned and teach Mediterranean approach, Mediterranean style approach of the diet. And we have some digital tools to control it or to measure it, and we teach this also taught for the families. How we measure the success, as it was a broad definition of it. So small improvements, but we expected from our work to have better sleep, improved fitness, more active play, greater confidence, and sometimes it was enough just as a goal that the clothes fit a little bit more comfortable. What we taught also to our doctors that it has to be a structured pathway. It's not a single consultation, but it has to go on quite lifelong if it's needed. We have to connect screening, risk assessment, as it was previously mentioned, of the Edmonton protocol, communication, how to involve family, how to change behavior, how to make the medical evaluation, how often the follow-up, and when to refer the children. Not every child needs the same intensity of intervention, and some just need some short preventive counseling, but others need structured weight management. What we emphasized also for our colleagues is that when to focus on particularly on those situations when some change is occurring in the child or the family's life, especially when they are going to school or they are changing some kind of environment, because they can, when there is a big change in the child's life, you can establish new habits, and a good habit will define your health. So this is just a little slides, how from which countries, which areas doctors voluntarily participated. The geographic distribution is only important because our aim was not to create experts in a central institution, but all broadly in Hungary. So when the same time that we trained our colleagues, we also applied some public communication, because we want the families to understand that they need reliable, understandable, and non-stigmatizing information about obesity and whom to turn with their problems. And also that to make families to understand that a conversation about weight is not a blame. So it's just opening a pathway to health. This message should be that we discuss about health and development. And we are also discussing about how daily functioning the child and how they are happy in the daily life, and what are the future risks. So we developed videos, online materials, and some public campaigns to continue what we start in the consultation room. After the first year of the training, we asked our physicians how they changed and what they experienced, because our aim was that after the first year to collect what we learned from our program and how to change, how to shift our aims. So what we agreed and what we saw that we understand that it's a clinically relevant state. Many practices didn't develop a structured weight management program, And also the physical parameters were not always measured consistently. So it was a little bit disappointing that because this show an implementation gap. And we have to recognize that obesity is important and doesn't lead I'm sorry, doesn't lead automatically to routine screening. The main barriers were also the attitude. And in the next, next slide, what is one of the barriers? That even already routine consultation is already short, but an obesity-related visit may require, as Dr. Pitti explained, that you have to measure and to assess the growth. You have to obtain a family history, dietary activity review, discuss the motivation, screening for complication, and we have to talk and share with the family the goals. So this is quite unrealistic to do it everything in one appointment. So the solution is to structure this kind of work and to divide this kind of work across several visits. And we have to do it with the whole practice team. And by the one visit, we have to only achieve one or two goals. We also examined the physicians, how they felt, and many didn't feel that they are ready to manage overweight child, even if they were seeing these children regularly in the practice, and why they and how they managed that if they didn't feel competent. They made it short, the advice, they directly referred to another level, or they just made a laboratory testing on or sometimes they simply avoid the topic. And what they want, so we asked our colleagues, what do you want more to learn? And what they want to learn more is the communication and behavior change. And I was happy to see that also you find this help, that how to communicate and manage children on this, and families, of course. So this is the frequency of screening in Hungary. These are the well-child visits. And what we also teach and emphasize that when you measure weight, height, and BMI, you have to make it as a trajectory, not a single measurement, but you have to see how is it developing. Because maybe a child can be formally or mathematically in the normal range, but can show a very rapid upward shift between the lines. And when there are the regular screening, we will recognize this risk even before obesity or serious obesity becomes, or we see complications. So this we made a very simple algorithm that because primary care is managing a big number of children, and we how and when to check anthropometry, and when there is relevant nutritional risk tool, for example, the strong, but the strong is emphasizing the undernutrition. And if the test is normal, we just make a routine follow-up. If a child is crossing 2 BMI percentile, since the previous measurement, this should prompt repeat measurement and immediate evaluation. And we also described what are the red flags when they directly have to refer them to the specialist. You can see down on the picture if you suspect endocrine or pituitary disease, very early onset obesity. If it's below age of 2, the background must be some kind of genetic background. especially if it is with some kind of developmental delay, if the obesity is extreme, or if you fail to change the lifestyle of the family, or the red flag also if you have psychiatric or eating disorders or you suspect it. The other, what we have taught for our colleagues, that in what level of readiness, what strongness to how to influence the family. And before giving detailed advice, we need to assess the readiness for change. Because if a family is not ready, even if you bring the moon, you will not be able to help them. So there must be a kind of motivation. And there is this psychological steps, that pre-contemplation, contemplation, preparation, action, or maintenance. And we have to be aware which level of readiness is the family. You can have to, if you want to decide which state is the family, there are some useful questions, and this slide we teach for our colleagues. For example, do you think the lifestyle change would improve the child's health? And this will help that if they are ready to change their behavior, or how likely you are to make any change in the next 6 months, or what are you already doing? And with these simple questions, you will be able to decide if they are ready to change and what actions you have to make. Before, it was also mentioned that this is also a management protocol, an interviewing protocol. The 5A method, the assess, advise, agree, assist, and arrange. And this is a very practical and very common method. You have to assess the health risk. You have to advise very clearly and, of course, respectfully. And I should mention the first, that you always have to ask permission. So the first question you always have to ask that, would you mind if I ask you a few questions about your child's weight? Because if they are not ready to change, you don't have the right to continue the consultation. But each time you can have this question. You have to agree on realistic goals, short and long-term goals. You have to assist them with practical tools. You have to write always written information, and not just talk about these things. You can advise applications, activity diaries, some kind of visual infographics, or any kind of community resources. But at the end is the most important is to arrange next follow-up. And one other, what I have to note, that to change family and the child's behavior, it's not a continuous, not a direct line to go up to the stars, but there are relapses. And this should not be described as failure. It is normal part of behavior change, and an opportunity to revise the plan. We made it together. This is a framework which we advise for our colleagues, that according to each BMI, we have to always ask the medical risk, the behavioral risk, and the attitude. And according to this, we have to plan our actions. For children in the healthy range, we just focus and revise the lifestyle, we reinforce them, and we target prevention if maybe there are risk factors. If they are overweight, we should assess the medical history, family history. We have to focus on the parental obesity, if it's present or not, lifestyle, diet, the regular physical activity, and the motivation, and sometimes laboratory tests may be needed. If the BMI above the 95 percentile, you have to more intensively assess and treat the children and the family. And the level of care should increase with the severity of the risk. And as you saw on the right side of the previous slide, there is the Prevention Plus. This is for the healthy and for the healthy children. And these are the main elements. You have to repeat for the families. I can read it, but you can read it too, that vegetables, reduce sugar sweetened beverages, the breakfast has to be regular, the family has to eat together, fewer meals outside of the home, at least 1 hour of physical activity, screen time, of course, this is very important, and if there is nothing special, it's better to regularly, monthly, just to check them, just to follow up them if you have any problem. And the family choose, if they are not all achieved, they have to choose a small number of these priorities, not all, because we think that a little sustainable change is more important than an intensive plan that they cannot maintain. And if the child is overweight or obese, we call it Prevention Plus. We call it structured weight management. And apart from Prevention Plus, this will include a little bit more strict, and this will include a specialist, because more intensive the support. The goal settings are explicit and very strict. We have to refer them to dietitian who will make a structured dietary plan, regular meals and snacks. We monitor their activity and eating patterns. We teach the parents how to reduce the screen time. They have to supervise the exercise. Sometimes medically, we have to review, and mostly this must be mostly follow up. This plan also should remain family centered, and we have to adapt it to the child's age, health, and also their developmental needs. So this is what we are teaching for our doctors, but the next goal is the community goal, is that the trainers, these colleagues who were practicing and learning this method, we plan that these colleagues will educate the other colleagues of their own region. And we hope that it will train and train the other colleagues and multiply this system, a wider professional network. The second component, because as doctors, we are not only responsible for this level, but of a national level, that during this time, as the previous presentation showed, that ultra-processed food are not only unhealthy, but bad for the child's health. We didn't have regulation of restricting this and of marketing these unhealthy foods in the media and around schools. So we made a public health working group, and we developed a draft law. And this proposal was submitted last week as to regulate and restrict the marketing of unhealthy food. We believe that the clinical education of colleagues and the public health, they must progress together. And I would like to show you how we are collecting data of school. In a central control room, we can see all the data of children. And this shows, maybe you don't know the Hungarian school system, but those children who are on the obese, they are the socially not so preferable situation. And the socially preferable schools, their children are more healthy. So because the human factors and all the financial factors are not unlimited, we are trying to focus on those groups which need a little bit more education or intervention. And from September, we will see all this data geographically, which area is affected and which school types are need intervention. And this is the community. I want to show you my city. They offer for, these are all free programs for exercise from younghood, childhood, till even to the very old age. And these are all free. And these are opportunities. Then the children and the families, they don't have excuses that they don't know how to exercise because these local programs, they are affordable. But I want to emphasize that not all children are in the pediatric primary care, but they are sometimes with GPs. And for the GPs, we emphasize that the BMI is in the childhood is percentile. And the waist to height ratio is different than for the adulthood. And that in adulthood is individual problems, but in children and childhood is family problems. So also we have to focus on as a family. So this is our main philosophy. Don't wait, because the perfect moment will never come. What you have, start, but if you know your goal, on the way you will find your tools to do the best. So thank you for your attention.
Thank you very much, Dr. Kantor. It's a very wide, comprehensive, but also practical presentation. Well, what do you think? Just a few discussion in the panel. Don't you think that an addressed education and counseling skills are some of the most important competencies for health professionals in obesity management? The question is up to all of you, and if there is some question from the audience, it will be pleasant to refer you, please, to the attendants. If they want to ask something, write it down in the list of the question and answer. Thank you. Do you want to say something, Dr. Frelut or Dr. Pitti?
Yes, I've been very pleased by my colleague's presentation. Thank you very much. What I would like to pinpoint is that when you intend to help a child for the matter of obesity, in fact, a pitfall would be to add a burden to the already existing burden of obesity. And you should not charge the child with some sort of guiltiness or unreachable goals, but really stick to what he understands and what he is able to cope with. And I think that sometimes failure comes from an inadequate evaluation of what the child feels and what he feels like changing.
Yeah. In primary care, it's very difficult to realize in a short time which is the real and the concrete problem of the child, and especially of that family with that child, because that's the most important problem for us in primary care. Do you want to add something, Dr. Pitti?
Yes, thank you, Professor
Thank you.
Reali. The point is that, but the advantage that the primary care pediatrician has when compared with the tertiary centers is that they have the chance to motivate much more to the family and the children than the specialist. When we when we receive children with obesity here in the hospital, we have a contact, and then next time will be in 3 or 7 months. So we are not, we don't have the capacity, we can motivate them. We can do this important motivational intervention that primary care pediatrician has. However, I think that as pediatrician, we are alone and we cannot be responsible of the whole problem. We need more people helping. We need the nutritionist, we need the physical activity expert, we need the psychologist, but in the middle, the primary care pediatrician, but with all that support. So the responsible of the pediatrician is to engage, is to motivate, but other professionals has to be with you making their job.
So that's a call to action for the building of a net.
Yes.
Evidently.
And a net near the houses of the people. That is another problem. That, for example, we have developed a net in the hospital, but there is a big problem, a big barrier that people from an hour far from Valencia came to our program. So this net must be developed near the homes of the families.
Yeah, completely agree, completely agree. So I suppose that we are at the end of the time, unfortunately, and I don't see a question in the chat. But I would like to pass the rule of presenter to Dr. Irén Kantor to say something hello and remembering for the next meeting of the third of this kind webinars, if you agree. Thank you for your cooperation. Thank you for your presentation. You have been wonderful. Thank you so much.
Thank you.
Thank
Irén,
you.
Thank you.
Thank you. Irén, please.
Thank you very much for all the participants. Thank you, Laura, for guiding our meeting. And if you don't mind, there is one more question. If you, Isabel, could you present it? If not, it's not a problem.
Oh, no, it's there. It's there. It's there.
It is.
Yes. Now it is not anymore, but it's there.
Thank you for Marie and Julio that despite we didn't talk before what our subject will be, but we didn't repeat each other. What we made is complete evaluation of from physiology to very practical questions. So I hope we made a nice broad view of obesity in primary care. Thank you very much for.
Thank you.
If I can add only one word, I would like also to thank you from the point of view of the European Confederation of Primary Care Pediatricians, because we are very, very glad to be here with you to discuss together about the net. And I'm involved with YASONet and ECONET, but we need to stay all together. And this is one of the first situations in which this happens. So thank you so much to everyone. Thank you.
And also EAP is thanking for everyone.
Yeah.
Have a nice evening.
Have a nice evening. See you on the next webinar. Please follow us. Stay tuned. Thank you.
Bye.
And then on Lyon, en France, on the next October, it will be a very nice meeting of the EAP and we, the European Society for Pediatric Research. We are a very active associations together. So please go on. Thank you.
Thank you.
Thank you.